Infective endocarditis. Etiology, pathophysiology, and pathology. Microbial infection of the endocardium develops as a result of a two-stage process. Non-bacterial thrombotic endocarditis, NBTE. A sterile mass arises from the deposition of platelets and fibrin on areas of endocardium injured from exposure to high-velocity jets, flow from high to low pressure chambers, and flow across a narrow orifice. Bacteremia with organisms that have the capacity to adhere to NBTE result in the formation of infected vegetation. Bacteremia rates are higher in the presence of diseased mucosa, especially if infected. The consequences of infective endocarditis, i.e., vary from trivial to catastrophic valvular and paravalvular tissue destruction. Risk factors for IE are classified as cardiac or non-cardiac and are summarized in Table 32. Epidemiology. The incidence of IE in North America and Western Europe remains unchanged at around 1.76.2 per 100,000 person-years. The risk of IE increases with age and it is more common in men. However, the risk profile of IE patients has changed over the past decade. Rheumatic heart disease is no longer the leading cause of IE and has been replaced by increasing cases of IE occurring secondary to intravenous drug abuse, implantation of intracardiac devices, hemodialysis, and increasing age. Clinical presentation and physical signs. IE can present rapidly, acute IE, or insidiously, subacute IE, over a number of days to weeks. Clinical features of IE are varied and at times it can be difficult to initially differentiate from other chronic medical conditions. Fig. 74. Features of systemic sepsis. Fever and rigors, sweats, general malaise, anorexia and weight loss. Local cardiac manifestations. New cardiac murmur, heart failure, pericarditis, and conduction abnormalities. Features of immune complex deposition. Dermatological, petechiae, most common, splinter hemorrhages, Osler's nodes and Janeway lesions. Ophthalmological, Roth spots, conjunctival and retinal hemorrhage. Renal. Features of glomerulonephritis and renal impairment. Embolic events. Septic emboli seen in 20–40% of cases including cerebral, leading to abscess formation and focal neurological abnormalities. Spleen, leading to pain secondary to infarction. Renal, resulting in renal failure. Pulmonary, causing lung abscess or pneumonia. Other arterial territories including joints and soft tissue infections. NB. IE must always be considered in a patient presenting with chronic fever, weight loss, and malaise, irrespective of the presence of a murmur. Elderly patients may present with little apart from confusion. The absence of the much overemphasized classic signs of Janeway's lesions, Osler's nodes, etc. does not exclude the diagnosis. Investigations. A definite pathological diagnosis can be achieved only via isolation or culture of the bacteria from material obtained from a vegetation or abscess. This is not possible in most patients, and diagnosis depends on a combination of clinical criteria. The modified Duke criteria, Table 33, based on a number of major and minor clinical and microbiological features are designed to assist diagnosis of IE. Cases are defined as follows. Definite IE, presence of 2 major criteria, 1 major and 3 minor criteria or 5 minor criteria. Possible IE, presence of 1 major and 1 minor criteria or 3 minor criteria. Unlikely diagnosis, presence of firm alternative diagnosis, or sustained resolution of clinical features with less than 4 days of antibiotic therapy. Blood tests. FBC. Mild to moderate normochromic or normocytic anemia. Neutrophil leukocytosis is usual in acute IE. Thrombocytopenia in chronic infections. Biochemical profile. Renal function, urea and creatinine, may be deranged. Liver function tests may be abnormal, especially alkaline phosphatase and gamma-glutamyl transpeptidase. Acute phase markers. C-reactive protein, CRP, and erythrocyte sedimentation rate, ESR, are typically elevated. Immunology. Polyclonal increase in serum immunoglobulins. Reduced complement levels. Positive rheumatoid factor. Microbiology. Blood culture. Take at least 3 to 4 sets of blood cultures from different sites, leaving around 60 minutes between each puncture. Discuss cultures with microbiologists to ascertain if there is a need for prolonged cultures and the use of specific culture media for infections caused by fastidious organisms and fungi. Serum. Take a sample of serum for immunological tests of atypical organisms, including Aspergillus precipitans, Candida antibodies, rising Brucella agglutinins, 2 samples required, and chlamydia complement fixation tests. See Table 34. Chest radiograph. This is usually normal. There may be evidence of pulmonary edema and areas of infarction or consolidation from septic emboli, often associated with involvement of the right-sided heart valves. ECG. Important to look for prolongation of the PR interval or higher levels of atrioventricular, AV, block, indicating involvement of the conduction system, commonly associated with aortic root abscess. Urinalysis. Microscopic hematuria with or without proteinuria is common. Heavy proteinuria and red cell casts indicate glomerulonephritis. Echocardiography. Transthoracic echocardiography is the first-line investigation for native valve IE, looking for evidence of new valve regurgitation and/or vegetations. If inadequate, negative, or non-diagnostic in a patient with high suspicion of IE, transesophageal echocardiography, TO, should be performed. TO is more sensitive for imaging of the aortic root, especially detection of an abscess, and the mitral valve, Fig 75. TO is the investigation of choice in suspected prosthetic valve IE. NB. A normal echocardiogram does not exclude a diagnosis of IE. Treatment. Medical treatment. Antibiotics are the main therapy. Blind treatment. Table 35 shows a sample protocol. Should be started as soon as a clinical diagnosis of IE is suspected, after multiple blood cultures have been taken. Early discussion with microbiology and cardiothoracic teams is important. Identification of the infective organism is invaluable and antibiotic treatment should be modified according to sensitivities. Duration of therapy varies according to the severity of infection and organism. Often a total antibiotic course of around 4-6 weeks is required, with intravenous administration during the first 2 weeks. All patients must be closely monitored to chart their response to treatment. Daily monitoring for clinical signs of ongoing infection, such as persistent fever, changing and/or new cardiac murmurs, and embolic signs. Regular monitoring of changes in acute phase markers, CRP and ESR. Regular urinalysis. Twice weekly ECG looking for conduction abnormalities. Weekly echocardiogram. Monitoring of antibiotic levels, especially for aminoglycoside antibiotics and vancomycin. Surgical treatment. Surgical treatment should be considered in the following scenarios. Hemodynamic compromise secondary to valve destruction. Inadequate response to medical treatment and/or relapsing infection. Consider early surgery for fungal and prosthetic valve endocarditis. Complications including formation of intracardiac abscess, high-degree AV block, recurrent septic emboli, perforation of intracardiac structures, e.g. interventricular septum and chordae, and unstable prosthetic valves. Prognosis. Endocarditis is a serious medical condition with a high mortality rate. Prognosis is variable and depends on the infective organism and clinical scenario. In an uncomplicated streptococcal native valve endocarditis, the mortality rate is 10%, whereas Aspergillus prosthetic valve endocarditis is associated with virtually a 100% mortality rate.